to re-emphasise what we said before. It's a life support technique, not a treatment. You've got to treat whatever the underlying condition is well. So you need to do your basic intensive care well as your ECMO care well. So the development of these double lumen cannulas, which have been mentioned, the Avalon cannulas, they're available from 13 French up to 31 French. They're not particularly easy to put in, and for those who don't have a surgical background, because mistakes can happen with it. And this is the physiology of these sorts of double lumen cannulas. They have a single return hole which is directed towards the tricuspid valve, and multiple drainage holes from the IVC and the SVC, so you don't get anything very much in the way of recirculation. Almost all the blood that you oxygenate does not mix back with the venous return. For ECLSR, to me they're the same principles for any age of patient and for any type of extracorporeal circuit. The basic principles are the same, and I don't think one should be too prescriptive about diseases. If they tick the right boxes, then you should consider ECMO. I mean, we have on an occasion even done elective ECMO for a lung wash. Now, if you've got a 2-year-old on a ventilator with alveolar proteinosis, how do you do a lung wash? It's extraordinarily difficult to do in a conventional way. It's extraordinarily easy to do on ECMO. And we had one child that we did elective ECMO on 3 occasions to do lung washes on it before it eventually got better. So there are circumstances which you wouldn't normally consider as indications for ECMO, which tick these basic boxes, and you should still consider them. So question 1 is the most important, and this is where I earned my money as an ECMO director, is deciding whether a case was potentially reversible or not. And it doesn't matter whether you're talking about pulmonary disease, cardiac disease, or cardiopulmonary disease. That is the most important thing. It's no good putting a cardiac surgery patient on ECMO if their heart hasn't been fixed. If the heart it won't work, with or without ECMO, what is the point of putting them on? You may have to have a very unpleasant discussion with your cardiac surgical colleague that he needs to re-operate on the patient, because otherwise there's no point in putting them on ECMO. They're not going to do. Now there's another important question, and that's the issue of ventilation and reversibility. Over the years we've understood that positive pressure ventilation causes significant pulmonary damage, and that damage is related to these 4 things. Pressure, time, volume independent of pressure, and also oxygen concentration. Ted Golubov, who invented that oxygenator, did a series of very elegant experiments which showed these various things. Even spontaneous hyperventilation can cause ARDS. Right? It's something we don't appreciate. We assume it's a ventilator only. No, volume trauma is caused by excess volume, not just by a ventilator. The effects of this damage do affect case selection, and these are the guidelines, and I emphasise there are only guidelines about selection of cases for ECMO in terms of length of ventilation, or should I say length of high pressure ventilation, which is more accurate.